At this time, I'd like to introduce our moderator, Liz Sabo. Liz, thank you for being with us. She's a senior correspondent for Kaiser Health News. Previously, Liz was a medical reporter at USA Today for 12 years. She dedicated significant time to covering cancer, both breaking stories and long-term stories. Please welcome Liz and our panelists.
Okay, can everybody hear me? I'm vertically challenged, so I'll try to get close. It's really great to be here today, and I want to thank you for inviting me to talk to all of these great scientists and these amazing patient advocates who've been through so much. It's really great to meet some people in person that I've interviewed and talked to for years, including patient advocates and amazing scientists. And I just wanted to say that I have a huge stack of business cards, and scientists are easy to find, but at Kaiser Health News, we're an independent nonprofit newsroom. We're not connected to Kaiser Permanente. We're constantly trying to find real people to include in our stories. So I have this huge stack, and I'll make them available. I'd love to connect, especially with patients and advocates and caregivers. So I'd love to, you can look me up, and I'd love to give these out. So cancer is such a daunting disease. I've lost 6 coworkers or former coworkers in just 3 years to cancer at USA Today and the Virginian Pilot, where I used to work. And another friend of mine from the Virginian Pilot is battling metastatic colon cancer right now. He has Lynch syndrome, which is this very rare genetic condition that increases your risk of cancer. So this is something I really, really care about. And cancer is so hard to fight when it does get really advanced that for years people have been looking for ways to find cancer early or look for genetic markers to try to predict who's at high risk for cancer, because the hope is that if we find it earlier, we can treat it more effectively. So our panel is going to talk about their research in trying to look for early detection and screening in a number of cancers. And I'm going to let them introduce themselves, and then we'll find out about what's going on now and what the future may hold.
I think I'm last. You want to start? Yep. Yeah. Okay. I'm Gloria Peterson. I'm a genetic epidemiology researcher from Mayo Clinic. My research program has been focused on identifying genes that increase your susceptibility to particularly gastrointestinal cancers and specifically pancreatic cancer, but I've worked extensively in colorectal cancer as well. In fact, helped discover the Lynch syndrome genes. My particular passion is obviously cancer research that relates to improving the quality of life for people who are detected early. I mean, that's really the main way that we can do this. And I am a long-term survivor of 2 separate cancers, and I really attest my survival and my passion to keep fighting due to the research that went before. I thank the patients and the researchers who have enabled me to continue my fight and my research to really make a difference in patients' lives.
I'm Douglas Lowy. I'm the acting director of the National Cancer Institute, and my research laboratory studies human papillomaviruses, and we discovered the main technology that underlies the 3 different FDA-approved HPV vaccines. In my capacity as the NCI director, we strongly support research that includes very basic research in terms of prevention, understanding the causes of cancer. We also strongly support prevention research, research to look at cancer screening for early diagnosis, also treatment and survivorship. And I really want to applaud the AACR for their efforts in trying to highlight not just cancer treatment, but also for prevention and screening. Because the great news about prevention and screening is you end up with no grateful patients. But the bad news is you also end up with no grateful patients. The potential for prevention and screening to interfere with cancer is estimated to decrease the likelihood of getting cancer by about 50%. So about 1 cancer in 2 could be potentially prevented if it were possible to intervene. And this kind of intervention really involves tobacco, so smoking cessation, obesity, infectious causes of cancer, and other aspects. Thank you.
My name is Avi Spira. I am a director of the Cancer Center at Boston University. By training, I'm a pulmonary and critical care physician, and I spent the last 15 years of my career trying to develop new molecular tests for the early detection of lung cancer, and also strategies for preventing, or a word I like, intercepting lung cancer before it even starts. Specifically, our group has developed a test now that's commercially available where you can measure gene activity in cells that line your airway if you've been exposed to tobacco smoke that will tell you whether you have lung cancer or at risk for developing lung cancer. And I'm really greatly appreciative of the AACR's efforts, as Doug says, to really focus on prevention at this meeting. So thank you.
Excellent. Good morning. Thanks for having me. My name is Kim Hall Jackson, and I am a stage 3 colorectal cancer survivor and advocate. I'm attending this conference as part of the Survivor and Scientist program, so I want to say thank you to them and thank you to Rachel for inviting me today. I will probably give a brief background about how my journey began and where I am now. In January 2008, I'm an event planner by profession, and I was honored to be working the mayor's inauguration in Philadelphia. And at that event, I had a small but concerning blood discharge. Was not aware of any family history or any other symptoms going on in my body at that time. I was 45 years old, contacted my primary and my gynecologist and said, something's not right. I am thankful that they didn't fight me too hard, but they did want to rule out some of the obvious. Hemorrhoids, fissures, just a number of things before we got to, let's get you a colonoscopy. We had a little bit of a battle with the insurance company because I was 45 and not 50, but my doctors and I aligned and I was able to get a colonoscopy. I can remember coming out of the test from that great, wonderful sleep, and the doctor saying to me, you know, you're very lucky. You're very lucky. I think what we found is early, and a couple words I remember at that time is carcinoma and C2. Again, I have no knowledge. I'm not educated in what that means. So in addition to crying, you start doing research. I later, a few days later, met the colorectal surgeon who did a second test just to the lower colorectal area. And I can remember coming out from that test and him having a discussion with me and my husband and immediately discussing a plan of action for the surgery, for the cut. He mentioned a bag. And outside of a pocketbook, I could not understand what he was saying about a bag. And he said it would be over here. And I can remember asking him, stop 1 second, are you saying that I have cancer? And he said, yes. And I said, continue. And I continued to cry. The bag was mentioned a couple times. No shoes, no matching shoes, just the bag.
Just the bag.
And, but I liked him. I really liked him. I think what made me really sign on and say this is my surgeon was he said, I'm going to cut this, I'm going to put it back together. He said, it'll never be as good as God made it, but I'm going to do my best. And I knew then he was my doctor. I knew then he was my surgeon. So I think this was December of 2008. Had a meeting with my family, discussed the whole process, had the surgery in February. Again, I'm stage 1, would have surgery, temporary ileostomy, keep it for 8 to 12 weeks, get it reversed, go on with your life. Had the surgery. At my 2-week checkup to remove stables and check the bag, I was told that the pathology report had restaged me. And I was not stage 1, but I was indeed stage 3. It was just another moment in emotion and research quickly. So I got 3 opinions in different hospitals in Philadelphia. I went to Pennsylvania, Chestnut Hill, and University of Penn Cancer Abramson Center, which is where I decided to do my chemo and radiation. And I built my own advocacy care team. Sometime my surgeon and my oncologist disagreed. But when they bickered, they were always disagreeing about how to save Kim. So I was okay with that. The oncologist thought that I should keep the bag on and go through chemo and radiation. I thought I should take the bag off. 1, because it didn't match anything. And 2, because I'm an event planner and have a lot of OCD, I need to have things happen in sequential order. So I wanted the bag to be removed before I went into chemo and radiation. The surgeon concurred. He gave me a test just to confirm that I was healed. We reversed it, and I began my chemo and radiation. From May until December of 2009, I did chemo, I did radiation, and then I did radiation with chemo infused. I dropped down really small to about a size 4. We're not going to talk about my size now, but it was just a really tough and difficult year. I went to work most of the time, got my chemo every other weekend, kept connected throughout the weekend for 46 hours. Nurse came over, disconnected me. Radiation happened in the summer where my husband could take me every day. And yeah, it was rough, it was tough. But I'm married, I'm a mother of 6 children. I was able to see my oldest daughter become a doctor. I was able to see her get married. I have 3 grandchildren. My daughter, Niara, is here, who's a Howard senior. She graduates Mother's Day. It is the best fight of my life, and I'm thankful that I am here.
Thank you so much. Thank you. So I think what we'd all really like is to see more survivors like Kim. And Dr. Peterson, can you tell us a little bit about your research and how you're trying to help create more survivors for pancreatic cancer?
Yes, I work in one of the most deadly cancers, and it is currently the long-term survival is very poor still, even though there have been improvements in therapy. And I've always been an advocate to really make, because this is a very bad cancer, the main reason for it is that over 90% of the patients are diagnosed at a very late stage when it has metastasized, because it's a silent cancer. It sits in the pancreas, which is an organ attached to your small intestine underneath your stomach. And so it just sits there, the tumor just grows there silently, and it's very late when it's ultimately diagnosed, when it becomes symptomatic. So I have always been an advocate for detecting it earlier and doing risk assessment, trying to understand what causes it so that we can actually get interventions done at a much earlier stage. The work that I do in genetics is really to study families in which this cancer is running through the family in order to identify genes. As a result of a very large collaborative consortial arrangement that we've done across the country and even internationally, we've identified a number of families, and as a result, we've actually been able to get into our knowledge and able to transmit to physicians that there actually are genes that might explain the familial pattern that we're seeing in these pancreatic cancer families, and that in turn is actually leading to genetic testing of the individuals and the families at risk. And then the question is, what do you do? The other actual high-risk group that we have been working on at Mayo Clinic is not genetics, but it's actually an observation that's been made that people who have pancreatic cancer have very large proportion of them actually have had diabetes diagnosed recently, let's say within the last 3 to 5 years. They did not have type 2 diabetes leading up to it. They just were diagnosed, and then within 2 to 3 years, diagnosis of pancreatic cancer comes. And we have shown that, in fact, the tumor caused the diabetes. So the first sign you actually have of pancreatic cancer is diabetes. But we can't separate that group of people who have the tumor from the type 2 diabetics, of which constitute 99% of, only a very small proportion of patients who have new diagnosis of diabetes actually have pancreatic cancer. It's a relatively uncommon cancer, so we don't want to worry every type 2 diabetic who's diagnosed. So we're working on blood tests to help separate the people with cancer from the people who just have type 2 diabetes. And I think that that kind of early detection strategy, along with the risk stratification we're doing by genetic testing for the familial forms, will actually help us to make a difference in those individuals, identifying the very high-risk groups who need to then have their pancreases examined, and who we can now use our epidemiology to make recommendations for lifestyle changes.
That's great. That sounds so encouraging. And Dr. Lowy, can you talk about what you've done in HPV for people who aren't familiar with this virus and the cancers it causes?
Sure. Human papillomavirus causes virtually all cases of cervical cancer, as well as a high percentage of a number of different anogenital cancers, especially anal cancer. But in addition, is the cause of a form of head and neck cancer that manifests itself especially in the tongue and the tongue area, so that a majority of those cancers are also caused by HPV. Worldwide, cervical cancer is the #3 cancer among women, and from a public health point of view, it is the #1 HPV-associated cancer. But in the United States, because of cervical cancer screening, the non-cervical cancers, these other cancers attributable to HPV infection, actually are more numerous than cervical cancer. The vaccine in people who have not yet been infected by the virus gives close to 100% protection. But the vaccine was initially approved for 3 doses for young adolescents, and it is difficult to get all 3 doses in, and you can imagine if it's difficult to do this in the industrialized world in the United States, it's even more complicated and expensive to do it in the developing world. So recently, the FDA approved the Gardasil 9, the 9-valent vaccine, for 2 doses for young adolescents to make things easier. And then NCI is conducting research to see whether even 1 dose of the vaccine might be able to confer long-term protection, because this would make it logistically and economically far easier for people to take the vaccine. Like all other areas of prevention, the vaccine is underutilized, and so efforts to try to increase its dissemination are done. I would like to say a couple of words in addition about cancer screening. Dr. Spira's area is on lung cancer, and I'm sure he will talk about it. But I want to talk about lung cancer in 2 respects. First, the main purpose of screening is to save lives. For lung cancer, we knew for many years that if you used X-rays to screen people for lung cancer, you could detect more undiagnosed or asymptomatic lung cancer, but it didn't save lives. It was only with helical clinical tomography, which is the standard now that is used for lung cancer screening, that it was demonstrated that you actually could decrease mortality rates. And I just want to make that distinction, because I think that what Dr. Spira is trying to do is really to increase the precision with which that kind of testing is done. Thank you.
Lung cancer is the major cancer killer. Dr. Spira, can you tell us how can we find this cancer now, and what are you doing to make screening and early detection better?
Yeah, and I was really excited by the panel's discussion earlier, the first panel around treatment, the advances that the genome and molecular research have yielded on that front. I think we're beginning to see a similar transformation occur on the prevention, early detection front that's trickling down from understanding the basic molecular pathogenesis of all cancers. Specifically in lung, and I think I'm the one who worded that terribly worded question around what's the cancer that's detected least common at stage 1. And it's from writing all these board exam questions where you try to intentionally mislead the audience, so I apologize. But lung cancer is the #1 killer because we almost always diagnose it late. When I started practicing pulmonary medicine 15 years ago, almost every patient I diagnosed was at stage 4. I remember the first patient I ever diagnosed with lung cancer. I was a fellow at BU. She'd come into the emergency room. She was in her 60s, had previously smoked, started smoking before you knew it was bad for you, done the right thing, quit more than 20 years ago, came in coughing up some blood. We did a bronchoscopy. We found a squamous cell lung cancer in her lung, and she died within 24 hours of the diagnosis. You imagine how traumatic as a trainee this was for me to see this disease and its consequences. If we go 15 years later to today, we're beginning to see hope. We're beginning to diagnose lung cancer earlier, and it's for the reasons that Doug mentioned. We now have evidence, good clinical trial evidence, that if we routinely screen high-risk smokers with helical CT scans annually, we can pick up the disease earlier and reduce its mortality, which is the key point. However, those technologies come with some side effects. The side effects here are we pick up a lot of abnormalities in your lung that are not lung cancer. There's a huge false positive rate. This is true for most screening modalities. It's not limited to helical CT, but it's a particular problem in screening for lung cancer. So what my group and other groups are now doing across the country is harnessing and leveraging the molecular information that we now have about lung cancer to have more precision-based approaches for diagnosing it. So if you have an abnormality on your CAT scan of your chest on screening, we can marry that with a molecular test in your airway to tell you whether it's likely that that nodule in your lung is a cancer or that it's more likely to be benign. Because what we will want to avoid doing here is biopsying the lungs of patients who don't have lung cancer. And just to give you a statistic that I think is scary, but it's real, about 1 in 3 patients that I send today for surgery to take out a piece of their lung that I think is cancer turn out to be benign. We call those futile thoracotomies. We accept that rate because we never want to miss a lung cancer. You know, the surgical dictum, I know there's surgeons in the room, you know, when in doubt, cut it out. But the reality is we're putting people through unnecessary, invasive, and potentially deadly procedures. And this is a consequence of screening that we have to address. How do we reduce the false positives? How do we do it in a more precision medicine approach? And that's essentially what my research and others now are hopefully beginning to show.
Well, this sounds great. We've got just a couple more minutes to talk to the panel. So if you've got questions, you can make your way to the microphone because we'll have 10 minutes of questions for you to talk to these folks. Kim, I wanted to ask you, now it sounds like you did not benefit from early detection. Can you tell us about what's your message to people now about screening to try to help other people avoid what you went through?
Sure. That's kind of my platform now for advocacy work. I do community events. I created an event particularly for African Americans to get screened for colon and colorectal cancer. The truth is that there are a lot of rumors, myths, untruths about what a colonoscopy is. Certain ethnic groups or religious groups are not comfortable with the process. I think education and communication and access is important to break down those barriers. The event that we held in 2014 was called the Black and Blues Brunch. So I had the opportunity to host an event that was sponsored by, with a grant from the state at a blues restaurant. Took away that white coat fear People came, they had a brunch, we had music, we had blues music, and we had a doctor talk about, in layman's term, what cancer is. We had a GI doctor talk about what the process is. Funniest thing is that she held up a pencil and said, I know you guys are scared about something going inside your rectum, but she said, truthfully, what you have coming out is 3 times as big, right? So people laughed and, and people concurred, but the truth is, it's a very small scope. And you're under anesthesia. People ask really good questions. I think a lot of fear, a lot of myths, a lot of untruths, particularly around getting a colonoscopy and then having erectile dysfunction. I mean, all kinds of questions came out, but it was in an informal setting. It was at a restaurant that's well known in the African American community. I fed them, we had music, we had fun, but we also answered questions. And at the end of the event, everyone took a pledge to make an appointment. Everyone that attended did not have to pay a fee, but they were told by their doctor, you need to get your colonoscopy. And there were 20 reasons why they had not scheduled. 20, if not more. But basically it was fear and untruth. So.
Well, thank you so much. Is there a question for our panel?
Yes, there are a lot of screening tests for colon cancer. If you were going to try to implement a program, say in an area of DC, largely African American with a very high colon cancer rate, what tests would you focus on? Sorry.
Let me try to address that. The different FDA-approved tests do have different characteristics, but I think that I'm not sure that one would necessarily be doing a global kind of approach, and this would be an issue that would be essentially addressed probably on a patient-by-patient basis. If what you're asking is, in a low-resource area, how might you do colorectal cancer screening? Probably the most cost-effective way of doing it is to begin with some kind of fecal stool test where if you are positive, it then gets followed up by a colonoscopy, because if you do colonoscopies on everyone, particularly in low resource areas, there may not be enough gastroenterologists to do it.
Yeah, I think that's the...
Let me just add to that. I think the stool tests that are now out there, one of them involves molecular testing of the stool for products of the tumor. It comes back to the point I was making earlier. We've seen now advances in our understanding of the molecular mechanisms that lead to colorectal cancer. And we can now leverage that information to develop relatively non-invasive tests that don't require a colonoscopy but could identify at-risk individuals. And I think that Cologuard test is one really nice example of where the field is moving towards.
So is that a practical thing you could do in DC? These tests are available?
These tests are available. If you watch your nightly news, I'm sure you'll see a commercial for Cologuard coming on. I think they have, forget the jingle, but it's go, send, something. They explain how to collect your stool sample and put it into a little box and ship it to the company.
And I would also add that the fecal occult blood test now is far more sensitive because it's an immunologically oriented test rather than the older test, which was a much less sensitive test. Again, technological innovation through research and then demonstrating that it is clinically useful is how we have been able to make progress in these areas.
In terms of actual, the practical aspects, the stool tests are ones where you do it in the privacy of your home, you mail it in, you don't really have to deliver a stool to a hospital or a doctor. So it's being tried to be made as convenient as possible for the patient.
Thank you.
Thank you.
Yes, for the lung cancer screening, if a CAT scan shows nodules in your lung, can a non-surgical procedure determine whether it's, for example, breast cancer metastasized to the lungs versus lung cancer?
Yeah, that's a great question. The answer is not yet. I mean, the tests are getting there. The test I mentioned earlier, we can distinguish a benign lesion from a lung cancer. One of the challenges for us is dealing with patients who have a prior history of cancer, come in now by helical CT with a new set of nodules that are potentially metastatic disease. We have yet to develop a very good test, a molecular test, to distinguish primary lung cancer in that individual from metastatic disease of a primary cancer type. But I can tell you there is ongoing research, and not only in my own lab, but in many labs across the country, figuring out the molecular abnormalities that characterize one cancer versus another in the lung, and potentially leveraging that information to measure things non-invasively in your blood, in your nose, in your sputum, that potentially could make that distinction and do it in a non-surgical fashion.
Okay.
So that's where we're heading.
Even if it doesn't characterize what type of cancer it is, if it is metastatic cancer in your lung, does it at least show up as cancer?
Yeah, so the current test, the one that we developed, it does. Okay. So that the test would tell you this is a cancer, it's not benign, you should go to a surgeon and have it cut out. What it doesn't tell you is whether that's a primary lung, a new cancer, or that's a metastases from a prior cancer that you've had.
Thank you.
Hi. Thanks, everybody. Really interesting to watch the broader research landscape and what's happening in the using molecular approaches for early detection. And I wanted to explore, how do you think we're doing in leveraging what we know on genomic expression and protein-based expression in cancers? And where do you think we're going in the next few years in combining genomic and proteomic science and technologies, and how might that change the landscape in the future?
Well, let me try to address that in two different ways. First, in the area of cancer treatment, the proteomic analysis is able to basically be superimposed on the genomic analysis, and you can do a lot of pathway analysis and understanding that if you only do the genomic analysis, it is not as precise. So you can understand in an individual patient the pathways that are being activated and inactivated better with the proteomics. The long-term goal there is to be even more precise in terms of giving the right drug to the right patient at the right time. In the area of cancer prevention and screening, my view is that the genomic analysis is only now becoming available. When the Cancer Genome Atlas research was started about 10 years ago, you needed much larger samples in order to do analyses than you need now. The technology, however, has developed, so it is possible to do an analysis of the precancers and to understand in quite a lot of detail the genomic abnormalities. The protein analysis is not yet there, but understanding that those molecular abnormalities, there are a lot of potential for trying to intervene. For example, Liz Sabo mentioned her friend who had Lynch syndrome. The NCI is actually supporting research to try to develop a vaccine against the preventive vaccine to intervene with predicting what the molecular abnormalities are going to be. This is high-risk research, but if it is successful, it could set the paradigm for developing vaccines against diseases that are not caused by infectious agents.
Can I make a comment? Because I think you're going to see a lot more of this integration of proteomics, genomics, and so forth. I think there's a tremendous, actually the stool test is one example, because what you actually have to think about is that the tumor itself, wherever it is growing, is shedding proteins into the bloodstream or into your GI tract, which makes it detectable, which makes the proteins and or the DNA of the tumor itself, the alterations that are detectable when you actually analyze the tumor, may actually be found in the circulating blood system, and this is called liquid biopsy. there's a tremendous amount of research going on improving liquid biopsy because the technology's gotten to the point where we can actually analyze a single strand of DNA or a single cell that might have been shed by the tumor. So this is where a lot of the technology is going, is on this very molecular level analyses that was just not possible 10, 20 years ago. It just was totally impossible. So now we're looking at detecting very tiny quantities of material that the tumor itself has shed. And that hopefully we're going to detect the material that an early cancer has shed, so that earlier detection will be possible in people who have absolutely no symptoms.
Well, thank you so much. This panel went by so fast. We're completely out of time already. But this has been fascinating, and I learned a lot. And thank you so much for sharing your knowledge and your advocacy.
Liz, thank you.
Thank you.
Great. Thank you, panelists.